Combined anterior cruciate repair with an autograft reconstruction. The first step consists in creating the tibial tunnel. A pilot hole is drilled to 4.5 millimeters with the help of the tibial aiming device set to a 70-degree angle. Next, a guide pin is placed to finish drilling to a diameter that matches the graft. During this step, a feeler probe is used to align the fibers of the ACL remnant within the axis of the guide pin. When the router arrives at the intra-articular portion of the tibial tunnel, the rate of penetration is slowed down to remain inside the remnant. At this point, the router can be seen rotating inside the ACL. Next, using a Smiley chisel, the proximal portion of the ACL, which scarred to the lateral condyle, is gradually removed by detaching, if possible, a few small bone fragments. The ACL is removed up to the posterior portion of the notch to release the entire proximal portion of the torn ACL. In the present case, the portion of the ACL which scarred to the PCL is also detached. The entire proximal portion of the ACL should now be entirely free. Using a knee scorpion suture passer placed in the anteromedial instrumental portal, a first Tigerling suture with a closed loop on one end is passed through the anterior and proximal portion of the ACL remnant. The first suture is pulled, and a second Tigerling suture is placed more posteriorly. With a shuttle suture placed in the tibial tunnel, the two Tigerling sutures are pulled through the tibial tunnel to free the notch and the anteromedial instrumental portal so as not to hinder the creation of the femoral tunnel, which will later be drilled inside out. The posterior portion of the notch is debrided with a shaver by keeping as much tissue as possible. A posterior white line is now visible. This capsular line reference serves as an anatomical landmark to position the femoral tunnel. Protective cannula is introduced through the instrumental portal and placed over the ACL remnant to protect it. The knee is then bent to 120 degrees and a pre-tunnel is drilled to a diameter of 4.5 millimeters. Once an eyelet-tipped guide pin is in place, a blind socket is drilled under arthroscopy to a depth of 25 millimeters. A shuttle suture is then placed in both tunnels to pull the graft through. The femoral tunnel is carefully cleaned to remove residual bone debris that could impede graft passage. The threads of the femoral pull-up device are introduced into both tunnels by taking care to keep the two adjustable loops outside the tibial tunnel. The two Tigerling suture threads are then passed through the two loops of the pull-up device. The graft is now completely placed inside the two tunnels, at which point the pull-up device is flipped and tightened against the lateral femoral cortex. Under arthroscopy, by pulling progressively and alternately on the two Tigerling suture threads, the proximal portion of the ACL can be seen being tensioned towards the medial opening of the femoral tunnel. The knee is then flexed, and the Tigerling sutures are pulled to make the remnant proceed forward. A final verification should be done to make sure that during flexion and extension there is no conflict with the roof and edges of the intercondylar notch, and that the graft is completely covered by the remnant. The native orientation of the ACL and graft has now been reproduced.